Okay. During break, we had a really good discussion. And again, I need to let everyone know, we are gonna do scenarios, so kind of everyone gets used to the steps. But we're just kind of touching on the skill today so that we can actually practice and hands-on Saturday. But one of the questions was regarding airways. When do we do this? When do we do this? So everything with airway management is typically we'll use the term rapid progression. So I'll use the scenario I did with the group we were just talking with, that we come in, we have a diabetic whose blood sugar has dropped really low. And they have a pulse, they're breathing, but they're kind of snoring. And, so if I hear snoring, first thing I'm gonna do is the easiest thing, is I'm gonna either sit them up in a chair, get them in a position, and manually, just physically, get behind them in the chair and open their airways. A lot of times, that fixes the problem. Okay, so we just position the patient to best facilitate airflow. And then I'll check their pulse oximeter, which you guys get a little probe, put that on, and let's say I look and the oxygen level is 96, I'm done. Now I'll just go to address the next problem. So I'm doing ABC. I open the airway, they're breathing, they got pulses, now I'll go address their blood sugar. Or I put the pulse ox on, I open the airway, and it's 80. Okay, it's too low. So now what I'll do is I'll put a nasal airway in. I'll look at the pulse ox. It's maybe 86 now. Okay, now I'll put a oxygen mask on top of that nasal airway. It's 96, we got that fixed, then I go. So things are like a progression, right? We try the easiest thing. If that's not working, we go to the next thing, the next thing, the next thing. The oral airways are, these are kind of a temporary step, unless that's the only tool you have. So not every EMR might carry an iGel with them. So if that's all you got, that's better than nothing. If you have an iGel, so we have a cardiac arrest and your job is to manage the airway, and you open up your pack and you have an oral airway here and an iGel here, just skip that step and just put the iGel. Okay, so we can progress kind of as needed with the patient, right? So we assess, determine what we got to do that, see how they respond. And sometimes we got to go another step, sometimes that step's enough. Nobody's the same, everybody's a little different. And I've had a lot of diabetics they're saturating fine, they're breathing fine, we just got to fix their sugar, but we still got to check it, right? So like I said, they're breathing good, they're saturating well, they're not making noise. I don't have to worry about their airway right now. We're constantly reevaluating it and reassessing it because it can change, but you just kind of progress with the patient. Does that make a little bit more sense? All right. Okay. The only thing I don't know if I'm going to get to the bag valve tonight, and this is probably the most dangerous piece of equipment that EMS carries, if not used properly. And we'll get into those details. So this is something I might just spend a lot of time with everybody on Saturday. This is a tool that all of you need to master, and we can get you through it. But it's a lot more than just breathing for the person. So assessment of breathing, and this is going to kind of get into our little bit of our oxygen therapies. We had talked a lot about, we're not only assessing their rate, but their volume. So are they breathing enough times a minute? And is it good enough volume? And usually for us, good volume is, do we see good chest? Is their chest moving with their breath, okay? A lot of times you're doing this assessment without even thinking about it. So I can tell you, like if I walked in a room and you were all my patients, I could go, okay, our airways, our breathing are good. It took me that long to do 17, 18 people, right? You can just tell by looking at them. You can tell when people are struggling or have an increased work of breathing. Just some of the terms, and I think we might have covered these already, tidal volume versus minute volume. So tidal volume, we can't really physically measure. So tidal volume is the volume of air that we take in with the breath. Minute volume is, or I'm sorry, how much air we take in and take out with the breath. And I should have Steve, the vent expert, when you're talking about this. But minute volume is you take that over the course of a minute. Okay, so that's just the terms, and it's, we're never asking you guys like calculate these volumes in the field. Okay. We know when we talk about dead space, and I might have mentioned this already, that the average adult takes in 500 milliliters, half a liter of air with the breath. This is again, just rule of thumb. Of that 500, 150 milliliters of that air is what we call dead space. So when we take a breath in, the air that's in our oropharynx, our nasopharynx, our trachea, our bronchial tubes, our terminal bronchioles, none of that is exchanging gas. Gas exchange occurs in the alveoli, those air sacs at the end of the bronchioles. Okay? So about 350 milliliters of the air we breathe in, that's what's being used in our chest. The 150 of it, that's doing nothing. So if I'm bagging an adult and I'm only squeezing the bag 100 mLs, I'm not even getting past that dead space into the lung. So like when we breathe for someone, we squeeze the bag until we see the chest move. That means we've got enough functional volume in their lungs to allow for that gas exchange. So how do we assess the breathing? Look, listen, feel. Auscultating, which is technically a little bit more intense listening. So, you know, look, listen, and feel. Listen is just we're listening with our ears. Auscultating is we're using a stethoscope. With listening to lung sounds, there's different terms for sounds, and we'll dig into them. I think the slides might get into, but where do we listen to lung sounds? For the most part, at the EMR level, I want to know, are they moving air in their right lung, and are they moving air in their left lung? And the best spot to initially listen is either on their back or in their armpits. And the reason is there's less tissue to listen to, okay? So even me, you've got, there's some muscle, some adipose tissue, and that's all stuff I gotta listen to hear those lungs. You get up in the armpit, and even a big person, you can feel ribs. There's not a lot of tissue between your stethoscope. So that's why a lot of times I want to know, are they moving air in the right, or are they moving in the left? I go just below the armpits in the axilla, and that's what, because I can hear good, or on someone's back. So if they're ever at the doctor, they might lean you forward, they put the stethoscope on the back. That's why they're doing it. And what this is showing, you can even get more in depth, but right, left, and a lot of times in my secondary assessments, which we'll learn about them a little bit later, I kind of want to know what's the air sound like high in the lung, what's it kind of sound like in the middle, and then what's it kind of sound like in the low. And there may be a vast difference. So take an elderly person who's got some mild heart failure. I listen high in the lung, they're sitting up. I listen middle lung. I listen lower in the lung. You get these crackles. And that's because they're sitting up, gravity kind of pulls that fluid down, that their lower lung fields might have some fluid or edema in there, but their upper lung sounds are fine. Okay, so a lot of times you'll hear the ambulance listen. Lung sounds are clear bilaterally, which means both sides. You've got crackles in the bases. And crackles just tell you that, hey, along the lines it sounds a little wet. And a lot of the lung sounds are subjective. So I listen, and if I hear something funny, because my hearing's going bad, first thing I'll do is take the stethoscope off and go, Julie, tell me what you hear. I'm not going to say, Julie, tell me if you hear crackles, because then she's going to go, oh yeah, maybe I can just tell me what you hear. And she might say, they sound good to me. I'll be like, all right, well, okay. Probably clear. I'll listen to her before you listen to me. Rate, rhythm, quality, depth. Again, this is just kind of, it's also a subjective assessment, and you're doing it without thinking about it. So when we had talked breathing should be regular, that when you see irregular breathing, it's very, very obvious. And irregular breathing is almost always associated with severely altered, if not unresponsive patients. Okay, so they're not awake and talking to you. Not sure how much this is gonna get into the different types of breathing patterns. I'm just gonna skip ahead. Did anybody read the chapter? Did it talk about who small, biatch, and Stokes, neurogenic hyperventilation? Any of those terms, like, oh yeah, no? So, and, well, just because I'm already there, we'll talk about it. So there's some abnormal respiratory patterns that we can see. We talk about, there's terms like Shane Stokes, ataxic, biatch. We don't really need to get down in the weeds on too much, but they're very irregular breathing patterns where they breathe rapid, they breathe slow, sometimes they just stop breathing for a little bit. These are super irregular and they're usually associated with like pressure on the brain. So the brainstem that controls our regular breathing. So we see this in a head injury from a car accident, right, where we've got significant head injury. Coup small respirations, this is a very deep, rapid, and we see coup small respirations with like diabetic ketoacidosis. And that's where blood sugars are super, super high, the person's unconscious, and because the sugar is in their blood, it's not getting to their cells, that they're unconscious. And they're blowing off all these extra acids, so they seen it a few times in my career. Hypoventilation would be someone who's just breathing really slow and shallow. Think someone who just shot up some heroin or fentanyl, you know, they start breathing slower and slower and slower, and eventually just stop. I wouldn't worry about it too much, but we'll talk more about them, especially when we get into medical emergencies. But there's, just in case you come across different patterns that we see. If breathing's inadequate, brain begins to die within 4 to 6 minutes. This is kind of a good rule of thumb. You know, this is why I am such a big proponent for that first response element. So, you know, when I came up here, yeah, we're paramedics, but we're not doing a person who's not breathing any good if it's taking us 20 minutes to get there. And the things the EMR can do to correct that, to buy time and create good outcomes for the patient, everything that we're learning in this class helps stop that timer and buy us some time. Respiratory distress versus respiratory failure. This is, the new curriculum touches on this a little bit, and these terms are not interchangeable. Okay. So as our breathing, we're not so much worried about necessarily what's causing it. A lot of things can cause it, but respiratory distress is essentially, I'm struggling to breathe, but I'm still talking, I still have mentation. It's, you know, they may present what I would call in extremis. They're struggling, and we've got to intervene. But when that respiratory distress progresses, they go into respiratory failure. This is where now it's beginning to affect their level of consciousness. The person's not responding to you anymore. And we may, and then, I'm sorry, the next stage is respiratory arrest, where they just quit breathing. And if they have a pulse and you go into respiratory arrest, it's not going to be for long. That they will then go into cardiorespiratory arrest. The respiratory failure, and if you respond on calls, you'll go on, and I'm picturing like a medical patient. Common one is like a heart failure. So person's in heart failure, their lungs are filling up with fluid, and you'll walk in that house, and they look very sick. They look like you look in the door, and we'll kind of teach you in assessment, sick, not sick. Like you look at them from across the room, they're sick. Like they're critical. And you get in and you know, Bob, how you doing? And Bob doesn't even, he's just focused on a corner in the room and he's breathing. That's respiratory failure. That his mentation is gone, that respiratory arrest is imminent, okay? And this, you know, we start doing treatment to try to reverse it, but respiratory failure is kind of that tipping point where I want to touch, because you guys are going to get in that point sometime when you're going to jump in, you're going to start intervening, and they tip the wrong way. And don't ever feel like, if I would have done this a little quicker, okay? That damage was done before your pager even went off, okay? And we jump in and we manage what we did. We didn't cause his heart failure. And I think it's important that we tell you guys that, because you're probably going to see it. That never say, well, if I'm trying to help that mental health thing now, right? Okay, everyone kind of knows where I was going with that. I touched on, yeah, we talked about this already. Abnormal breath sounds. We talked about stridor, upper airway. We get into wheezing, crackles, silent chest, unequal breath sounds. Just kind of touch on that. So wheezing, usually it's heard with a stethoscope, but so we hear wheezing with restrictive airways. So remember we go down the trachea into the bronchial tubes, and we start to get into those smaller airways. And in the smaller terminal bronchioles, they've got, remember we showed you muscle around them? So they're starting to swell and constrict. And when you're almost making a funnel. And a lot of times, like asthma, we'll get air in that funnel, but it's hard to get that air out. So when we take that airway and we decrease it, and we're trying to still push the same volumes of air, that manifests with the wheezy sound. That you listen with the stethoscope, and you might get this. It's my best wheeze. Anybody better at it?
Pretty good.
That's pretty good.
And so in you know, like we would turn that where that's expiratory wheezing. So you listen when the air went in, it's clear. When they exhale, we hear the expiratory wheeze, right? Sometimes you don't want to hear it with a stethoscope. Other times you walk into a house and you're walking in the room and you can hear them in the other room. That's now called audible wheezes. So we're kind of progressing here, right? They're getting worse. And if we take that asthma attack and we don't do anything, we just sit and watch them, and they keep getting worse, eventually it's going to be nothing. Now that's silent chest. Does that mean they're getting better? No. That means now we're not moving any airflow through those areas. So silent chest, if you listen and you're going, oh, I don't hear nothing, and they look like they're, you know, struggling to breathe, that's a silent chest, and that's pretty much impending respiratory failure. Okay, so that might be the person we start treating them. We give them oxygen, and like the EMR, we'll learn how to give albuterol. We start opening that airway up, or now we're listening, now they're wheezing. They're not getting worse, and we just got to go the other way in reverse, so they're actually getting better. We can start to move air with them. Crackles, a couple different terms, and I've always struggled, like crackles is usually kind of a wet popping sound. Rals, ronchi, help me Steve, what's the difference between the two?
Rales and bronchi.
Yeah.
Really, when you're breathing out, I believe, when you hear it, like that.
It's a wet sound.
Yeah.
Like air bubbling in water. And you can hear it with a bad pneumonia. Example, like I'm listening to their lungs and it's good and clear, and then over here, it's real gurgly here in this spot. Well, they got, you know, our lower lobe pneumonia. So it's sounds junky here, but everywhere else it's fine. Now that pneumonia can eventually progress to both lungs. That's bad. And you take a really bad pneumonia and a really bad heart failure and you listen to them, they sound exactly the same. Our treatments are very different.
How do you distinguish walking pneumonia from actual
walking pneumonia from actual pneumonia. So walking pneumonia is typically got pneumonia, but you're walking around stable. Right? Yeah, that, usually, they can both present the same. It's just how is that patient able to tolerate? You know, but there's other things in our assessment, when we're doing our patient assessment, that will start to further differentiate. You know, is this pulmonary edema, is this a pneumonia? So like pulmonary edema, you generally don't have a fever. You know, and a lot of it's history too. That how were you an hour ago? How were you this week? You know, a heart failure can just, I was fine, and like, you don't get pneumonia in 5 minutes, but you can go to heart failure in 5 minutes. You don't develop asthma, you don't wake up with asthma. You don't wake up with emphysema. It's a progressive kind of obstructive disease, right? So, you know, I get the person who, you know, all of a sudden is at work typing, and all of a sudden, I can't catch my breath. It's not you know, do you have a history of asthma? No, it's not asthma. You don't just get asthma like that. That's probably like a blood clot or something like that. And again, not asking you guys to diagnose, differentiate, I'm just throwing these out for examples. Unequal breath sounds, again, a lot of things, but I talked about the pneumothorax, the chest injury, that if it's a really big, and I got this big block of air in here, and I listen, it's really distant, where, yeah, I can hear some airflow, but then I compare it to the same spot over here, and it's, I can hear good airflow, and then I don't hear much over here. You know, I got, you know, what are we there for? Was this a car accident that you got hit on this side? Well, probably a pneumothorax. But one thing to do is ask the person, hey, you got both lungs, right? Because I've had it where they got a pneumothorax, and the patient's like, no, don't have a lung on that side. Oh, okay, well that, you know, so a lot of times just ask the question. Not very common, but. Paradoxical chest wall movement, so like during patients, will expose their chest, and as they breathe, you pretty much just kind of, you literally look at their chest. Are we seeing equal, symmetric chest rise and fall with breathing? Paradoxal motion is maybe where you see this. Okay, and it might be one little square that's doing the opposite of the rest of the chest. And again, jumping ahead a little bit, but that's a flail segment when we break 3 or more ribs in 2 or more places. So you've got this section of floating rib that's not going with your body. Believe it or not, we used to put sandbags on that. Remember? Or they teach you that? Oh yeah, we used to carry sandbags in an ambulance. There's nothing like someone who's in impending respiratory failure. Let's put something real heavy on your chest. Let's see if it makes it better. So just again, I'm kind of trying to just find stuff that's specific to the EMR.
Is there any way to mitigate pneumo or pneumothorax in the field, or is that ER stuff?
It's ALS stuff. ALS can, in fact, I'm just going to shut the PowerPoint off at this point. So if you've got a air building up in your chest, you know, it's going to continue to build up and kill you quickly. So paramedics can do a total chest needle decompression or a needle thoracentesis. So we basically just introduced a really long IV needle, pretty big gauge, 14 gauge, 10 gauge, and poke it in a certain anatomic spot, like the air pressure. And then when you go to the hospital, they'll put a chest tube in, hook it up as such. I do want to just go over oxygen therapy briefly with you. What time is it? Someone help me? It's 8:30?
It's like
8:40.
All right. Medical oxygen, so when we're treating, and we're going to spend with breathing emergencies, we'll get a lot more in the finer details of respiratory assessment, but One of our common therapies is oxygen therapy. So some EMRs may carry an oxygen tank in their kit, or if you're working with an ambulance, this is something that very well may need your help with. There's different sized oxygen cylinders, and a lot of them are proprietary, so where we get oxygen from, this is labeled as a D. D as in dog cylinder. I'm gonna pass these around in a little bit. So this particular tank, this is a key that's on some tanks. This tank doesn't need it. This tank has a valve here that will open and close the oxygen. Others are just it's got just like a nipple on that you gotta put this key on to open it. So all oxygen tanks are gonna be designed the same way. And they do this so that when we're using an oxygen regulator, we can't inadvertently put it on a settling tank. These only fit oxygen. When I pass it around and look at it, you will see one side, both sides are different. This one's got two little guiding holes with the air out. And when you look at the regulator, this is what takes the pressure in here and brings it down to a usable pressure out through the regulator. This has kind of the two knobs that line up with it. I guess it's my non-fancy way of trying to explain it. It's easier if I can show it. Inside here, there's also, you'll see a gasket that attaches in here, and sometimes those gaskets go bad, so we carry extra gaskets. And when you first put a regulator on, hook it up, turn it on, you hear air leaking a little bit. 9 times out of 10, just make sure it's seated right, check, and replace the gasket. For the most part, this is already done, that we're not swapping regulators from tanks. There may be times on a call where we're using excessive amounts of oxygen, where we have to go get a third or spare tank that doesn't have a regulator on it. That's when we have to swap these off. But they're pretty much, you just line it up, and it just kind of fits in. Just tighten it down. Doesn't have to be super tight, and then when I turn the tank on, you don't hear air leaking, everything's good. So now oxygen is is in the regulator, ready for me to give it delivery. This is that on-off, so again, I can shut it off there. If you just see the knob, that's what you need to keep. This then allows us to set liter flow, so when we administer oxygen, it's based on liters per minute, LPM. This gives us options of I can go to 1, 2, 4, 6, 10, 15, or 25. Max is all at 25 liters a minute. The different devices we use all might get different flow rates. Pass around if you have it. Feel free to, you can loosen it up and kind of play with it a little bit. So when we're giving oxygen therapy, and I'll start from kind of least invasive to most invasive. Least invasive is the nasal cannula. Nasal cannulas, this is probably a test thing. We administer them on the low end, 2 liters per minute. On the high end, 6 liters per minute. Can we go higher than 6? Absolutely. You can run a nasal cannula at 25 liters per minute. But what I will tell you is it is very uncomfortable for the patient. You're power washing our muscles with oxygen. So usually 6 liters a minute is kind of max, and if we don't feel that's enough oxygen, we go to the next device. The nasal cannulas, when we put them on, you kind of look, they're kind of curved down, so I get them so they go in my nose and kind of curve like that, but you pretty much line them up with the patient, put the 2 prongs, and they just sit in the nostrils, and then I usually run this behind their ears, like that, and it holds it. It's got a little slide here, and I always, when I grab it, I put my finger above it. Some of our patients have little waddles, So you don't wanna pinch, it's very easy to pinch their skin in that, so that's why I just put my finger on, run it up there. Down, it's not going anywhere. Hook this up to my oxygen tank here, and I would start at 2 liters, anywhere between 2 and 6. For me, a lot of times I just put it to 4, let's see how they do. If they do good, I leave it there. If they need more, I go up to 6, so on and so forth. So that just delivers oxygen. We do have another device, which in Saturday, I will go over end-tidal carbon dioxide with you a little bit. This is called the capnography cannula. It's just a little bit different in that not only does it administer oxygen, and it's not gonna fit because it's a pediatric. I put it on just like I do normal oxygen, and this end gets hooked up to an oxygen tank, and this end gets hooked up to our carbon dioxide, end-tidal carbon dioxide meter. So not only am I administering oxygen, I'm able to read how much carbon dioxide they exhale. We'll spend some time on Saturday, and we'll talk about end-tidal carbon dioxide measurement. So again, cannulas, 2 to 6 liters a minute. Kind of mid-range, and we only use this type of system when we're delivering a medication, is the nebulizer. This is, these run between 6 and 8 liters a minute. We only use these to deliver med. It's got a medication. Take this off, and we're gonna spend, everyone's gonna practice doing nebs at some point. There's a little, I don't know what it's called, but this is what aerosolizes the medication. So if you're ever putting these together and that falls out, and hook it up, and it's not misting, it's because this thing fell out. So you basically put your medication in here, like if I was gonna give someone a breathing treatment with albuterol, you literally squirt the albuterol in there, put it back on, hook this up to oxygen between how much? 6 to 8 liters a minute. Hand them this, and they breathe that medicine in. There's also a version just like this, but it's a mask that we can hook on the patient, and that's still 6 to 8 liters per minute. So nebulized medication is always 6 to 8 liters. As we progress up a step, probably the next step, and this is kind of the last ditch thing before we start doing airway adjuncts. This is an oxygen mask. This one is specifically known as an oxygen non-rebreather mask. We use this, minimum liter flow is 10 liters a minute, so we have to start at 10. When I plug this into the oxygen tank, it should fill this bag up. The bag does not have to be inflated for it to work. Okay? A lot of times when I open it up, I open this up, and before I hear, if I can, I'm just gonna use this real quick. This is hooked up right. So I'll turn my oxygen on. I'm gonna set to 15 liters. Oxygen gets hooked up here. I'll put my thumb over this quick, get some air in here, and then I'm gonna start, let's put it on.
Minimum of 10 liters?
Huh? No, I would need the net mask, which is just basically that medication thing that sits on the bottom. And the medication mask is still 6 to 8 liters. This is more what we call high flow oxygen, 10 plus liters. And this is what I'm, we're putting this on. For me, it's either a temporary thing that, it's very seldom that we just maintain this, that we would usually go up a level. There's another device called a CPAP device that's getting a little bit more aggressive. That's not in the EMR scope. We'll go over it kind of in respiratory emergencies in case you have to assist with it, but the CPAP mask, that's when the exhale it's pushing some pressure back to try to open up those areas. Okay? So that's the next aggressive one. So for me, the non-rebreather, we're either putting it on and we're able to fix them and they get better, or we're going another step up. So this for me is typically a bridge that I'm temporary. I don't know, Steve, how often do you put someone on a non-rebreather and keep them on?
Not very often. If you're at non-rebreather, you're usually progressing to something else, honestly.
If I walk in the door, like we said, at respiratory distress patient, so a lot of my other more aggressive airway breathing equipment takes some time to get it ready, to get it set up. This is something I can just real quick, we walk in the door, we may say non-rebreather, now, that we just do. Before we got an oxygen saturation, just get it on, start oxygenating them. Even if we have someone who's talking, but we think we might have to put a breathing tube in them, and their oxygen sats are like 96%, I'm gonna put this on them because I wanna build up this big airway cushion for when we put them to sleep. Kind of lastly, the most aggressive is the bag valve mask. Same thing as an oxygen. These are, you're pretty much running at max flow. So this one we would run at probably 25 liters per minute. It's got a reservoir bag, not necessary for it to be inflated. If you want to inflate, a lot of times hook up the oxygen, do this for a second or two, it inflates this bag. We can use this without oxygen, I can use it with room air, so if I was to breathe for you right now with this, it's just giving you what air is here, right? This is, and I don't know about this one, but these are probably about, this is probably a 1200 maybe. But 1200 milliliters of air. How much did I say was your vital volume? 500. So I don't want to put all this air in. Right? We can actually put too much air in. But we're going to practice with these a lot on Saturday. And with the bag valve mask, to really use effectively, we have to have a good seal. So this has to be, otherwise when I squeeze the bag, air is leaking out through the sides. The masks are detachable, and these are all adapters that, 15 millimeter adapters that hook to all of your airway devices or breathing tubes. So we can hook them direct to tubes. We actually also have an adapter that we put in between that reads that carbon dioxide we're talking about, okay? So with the bag valve, you'll hear us refer to the CE technique. The CE technique is make a C like this with your hand, and then the letter E. So I'm using that C around the top of the mask, kind of pushing down. And then I use my fingers in the shape of an E to grab that jaw and pull it up. So I'm pushing down and pulling up, kind of doing this motion with that mask. This is not ideal. Ideal is, I sit here out of the way and just hold the mask while someone else is squeezing. This is the best way to use a bag valve mask. It should be a two-person technique. Yeah, we're going to spend a lot more time with this on Saturday. So it's probably what, 1:45, 10:02?
10 minutes.